knowing your anatomy, your anatomic parts, because, we shame so much of our vulvar and of our genitourinary anatomy that we just call it down there. We have all these euphemisms for it, but actually naming the anatomy and naming what's happening is very powerful for people.
Hi, I'm Dr. Avanti Kumar Singh, and this is the Healing Catalyst podcast. I'm a medical doctor with over 20 years of experience and also a lifelong practitioner of Ayurveda. I created the Healing Catalyst podcast because we all deserve a different kind of conversation about health, one that's honest, holistic, and rooted in both science and soul. On this show, I'm joined by the world's leading experts to give you science-backed tools that you can start using today and actually stick with to build real health and longevity. I am so glad you're here. Now let's get to it. Hello, my beautiful friends. Welcome back to the Healing Catalyst podcast. So today I have a question for you that I want to start this episode with. Have you ever taken a mirror and actually looked at your vagina? Okay, I know it's a really weird question, but I'm very serious. Have you? If that question makes you pause or feel a little uncomfortable or maybe even laugh, it's because for so many of us, we've never been encouraged to really look at or get to know this part of our body. And that's exactly the kind of cultural conditioning that we're here to unpack today with my guest, Dr. Sameena Rahman. Dr. Rahman wants you to embrace your body, your sexual health, and your fullest life. And so she's made it her life's work to empower women with real information and clarity around sexual health. And so today she's going to walk us through how to understand our libido and what's really behind those midlife symptoms of vaginal dryness and recurrent UTIs that can make sex so painful and, let's be honest, not so interesting. And here's something that I know I'm living through myself, which she really explains and really gets us into conversation about, which is that when you're in the sandwich years, caring for kids on one side, aging parents on the other, also your partner, managing a career, maybe starting a new business and running a household, the mental load can be exhausting. I'm exhausted just saying it out loud. And so what Dr. Rahman reminds us is that it's not just about energy. This mental load can deeply affect your sexual desire and your sexual health. And yet, it's still something that almost no one talks about or says out loud. And so today, we're putting it all out on the table. The questions we may not have felt confident enough or safe enough to ask anyone. Because here's the truth. For far too long, women's health has been treated as an afterthought, especially the more nuanced and unspoken aspects of our sexual health. Things like vaginal dryness, low libido, hormonal shifts, or perimenopause and postmenopause have been minimized or dismissed completely. And too often, women have been led to believe that these changes are personal failings instead of what they really are: legitimate clinical issues that deserve real care. As a result, so many women feel confused, ashamed, or embarrassed to talk openly, even with their close friends, about the changes they're experiencing. And I know from my own life and my own cultural background as a South Asian woman, there's been so much silence and shame around our bodies, around sex, and anything to do with women's health. I still remember arriving at college completely clueless about sexual health, beyond the very basic and honestly very awkward information that I got in my high school sex ed class. My best friends from college and I still joke that we learned more about sex and sexual health from each other during our first year than from any official source. And yes, it makes us laugh now, but when I think about it, when I really think about it, it actually is not funny at all. We were just piecing together information, trying to fill in the gaps that no one had bothered to teach us. But thank goodness, slowly that is changing. And this episode is part of my deep commitment to really making sure that those changes keep happening by having the honest, informed conversations that women really need to have. And so today I'm joined by my friend, Dr. Sameena Rahman, a compassionate, deeply knowledgeable gynecologist who is truly rewriting the script on women's sexual health. Like me, Dr. Rahman is South Asian, and we personally have talked about how in our culture, there's a lot of silence and often a lot of shame around these topics of sex and sexual health. And of course, this isn't unique to our culture. Many women from all backgrounds experience this. But Dr. Rahman is really using her platform and her expertise to dismantle that shame and replace it with clarity, confidence, and agency. At one point in this episode, she says something that I honestly want to put on t-shirts. I've told her we have to do this. She said this: "We are not going to do patriarchal medicine anymore." And I think what she really means is that she wants to redefine sexual health, not through a lens built for men and by men, but one rooted in the lived experiences of women. It's about giving women the tools, the language, and the power to care for themselves fully and fearlessly. And what's so wonderful is that right now, women's health is having a real moment. In fact, I first met Dr. Rahman at a screening here in Chicago of The M Factor, a powerful documentary about perimenopause, menopause, and postmenopause by Tamsin Fadal. Now, you have to make sure that you watch it if you haven't already. And after the film, Dr. Rahman and I were part of a roundtable discussion with other women's health physicians. And I left that morning so inspired by her voice and her vision. I just knew I had to have her on the podcast. Let me tell you a little bit more about her. Dr. Sameena Rahman is a board certified OB-GYN, menopause specialist, and fellowship trained expert in sexual medicine. She's the founder of the Center for Gynecology and Cosmetics in Chicago, where she provides compassionate, trauma informed, evidence based care for women at every stage of life. With the very rare designation of ISSWSH Fellow from the International Society for the Study of Women's Sexual Health, Dr. Rahman specializes in sexual pain, sexual dysfunction, and menopause management. And she also holds the designation of Certified Menopause Practitioner from the North American Menopause Society. She's also a clinical assistant professor of OB-GYN at Northwestern University's Feinberg School of Medicine. Previously, she also served on faculty at the University of Southern California's Keck School of Medicine, where she trained residents and medical students and worked internationally on women's health initiatives, including medical missions and a collaboration with the World Health Organization in Switzerland. Dr. Rahman also sits on the Forbes Health Advisory Board and the Advisory Board for Flow Health, and her expertise has been featured in Cosmopolitan, USA Today, Women's Health, Yahoo Life, Parents.com, Pop Sugar, Very Well Health, and WGN TV. She's also a nationally recognized speaker and hosts the podcast Gyno Girl Presents Sex, Drugs, and Hormones, where she breaks the silence on taboo topics in women's health with clarity and candor. This conversation is an honest, empowering, and very practical conversation. And my hope is that it inspires you to ask the questions that you've been holding back and to really advocate for the sexual health that you deserve. Now, let's get to the episode. Hi, Sameena. I'm so happy to have you here today. Thank you for joining me.
Thank you, Avanti. I'm so excited to be here. Such a big fan of yours.
Oh, the feeling is mutual, totally mutual. You are such an expert in sexual medicine, sexual health, that I think that this is going to be such an empowering conversation for so many of my listeners because they have so many questions about what's happening to them as they enter midlife,
Right.
with their libido, with painful sex, like all of these things that we don't want to ask questions about because we're afraid or we're ashamed of it. And so I really hope that that's what we can really help people with today.
Yes.
And you're the perfect person to talk about this. And also, I just have to shout out that, you being a South Asian woman, South Asian physician who is in sexual medicine, like right there, hats off to you because, culturally, this is not something that we would talk about at our age, our generation.
Yes.
And for you to be practicing, and you are one of the small handful of experts in this field, in this country, it's so amazing. So I'm so excited.
Thank you so much.
Yeah, absolutely.
No, we try. Every time I meet some medical students and, we try to recruit them in and had a couple of people who come and train with me. So hopefully it's expanding a little bit.
Yeah, no, I think it's so important. And I'm so excited. So, I really wanted us to start with sort of some of the subjects, the topics that women have so many questions about. And I think the first one to start with really is libido.
Yeah.
What happens as we get into midlife and our libido starts to change, it starts to decrease, and so many women will ask, why is my libido, my sex drive low?
Yeah.
And so what's really going on here? Could you explain that to us?
Yeah, and it's so complicated. I think that libido is complicated. I think there's not a linear route from desire to orgasm as it was once thought, that's a male model, with the Masters and Johnsons where you go from arousal to orgasm to post-orgasm state. But I feel like it's very complicated for women, especially midlife women, because we have a lot going on. I talk to my patients, I would tell them that, our brain is our biggest sexual organ, right?
Right.
And sexual dysfunction, it is the most common complaint. Low libido with bother, right? Like I'm bothered. I want to have sex and I can't. And so that's called hypoactive sexual desire disorder. And it is the most common sexual complaint in midlife, upwards of 40%, some even higher if you look at other surveys of people complaining of low libido. But what tends to happen is, again, your brain is your biggest sexual organ. We talk about excitation and inhibition when it comes to sexual response, right? Because it's the sexual tipping point. What brings you into an excitatory mode? What brings you to an inhibitory mode? So I like to say it's like the let's go versus, hell no. Like, where are you at, right? Like, what's your let's go? What's your let's go is like, from a biologic perspective, it's testosterone, right? It's a big mediator of sexual function. There's oxytocin, which is another hormone that mediates sexual function. And then you have these neurotransmitters that are so important, your dopamine, your norepinephrine. And then on the opposite scale, you have like the hell no, like that's your serotonin, right? People don't ever realize that when like women enter midlife, they are 4 times as likely to experience like anxiety, depression, all these symptoms and get these SSRIs.
Right.
But a lot of times they don't get told that the sexual side effects from them because serotonin inhibits sexual desire, arousal, and orgasm. And so that's one thing. And then things like prolactin, opioids, other things from a biologic perspective. And that's biology, right? That's your brain. But what else is happening? We treat sexual dysfunction in a biopsychosocial lens. So there's psychology behind it, right? Like if you're depressed and one of the main symptoms of depression is complete anhedonia, lack of desire to do anything, sex is going to go along with that, right? So if you're completely depressed, you're inhibited and you have no motivation to do anything, that's going to be number one. If you're completely anxious all the time and you're ruminating and you're having these, what I call brain hiccups, you're going on and on thinking one thing after another, sex is not going to be part of that rumination usually. So there's like these mental health loads that we carry, which is around anxiety and depression, which comes when we start having hormonal shifts, right? Because estrogen modulates all of the neurotransmitters that are so important for our mood and our overall quality of life. So depression, anxiety start to really come into the equation for a lot of perimenopausal women. And then there's like the social aspect, right? Like you're in a relationship for over 20 years, like the excitement's gone. We know that in heteronormative sexual relationships where the gender roles are pretty classic, right? Male gender roles and female gender roles. There's studies that show that people that are in these heteronormative relationships with women who are having sex with men, they actually have lower desire related to a lot of household work, right? I always say if like you're the one doing all the dishes every day and you're cleaning up after the kids and you're the one doing the daily grind and the mental load from that, on top of the fact that, you might be the one that has to take care of your significant other, it's a no-brainer that libido goes down in that scenario. You're not motivated. And my patients tell me this all the time. They come home exhausted from work and their husband is sitting on the couch and they're looking at them like, oh, I still have to make dinner, take care of my kids, go check on my parents, like all the things, like I don't get that decompression time. So that mental load of really having to deal with all the social aspects of your life. And as women, we're natural caregivers. So we carry a lot of burden on us. We are in a sandwich generation. We're taking care of kids. We're taking care of parents. We're taking care of our careers if we have them. Like it's a lot to juggle. And that becomes sort of the last thing on the equation. So it's biopsychosocial. That's why they always joke, those memes that go around with a man who has no shirt on and he's got a vacuum in one hand and a baby in the other and he's got an apron on. And they said, this is porn for women. Like it is. Like women are, they want that. They want to have like that mental load taken off of them. And so there's that. So there's all of these things happening in midlife. Some people are at the pinnacle of their career, right? They're all of a sudden they're doing these great things that they weren't doing before, or kids are out of the house and now they're transitioning. And there's so much going on for women in midlife that it becomes almost impossible to want to like if you want to have sex, it's like amazing. And then you bring into the menopausal effects, which we can talk about when it comes to like your genitourinary symptoms and sexual pain that comes about, that the combination of all of this
Yeah.
is astounding. We always joke in like the menopause realm that with our menopause buddies is that we can give hormone replacement therapy, which is what it's been traditionally called, but we can't do husband replacement therapy. That's on you. So yeah, if you're married to an asshole, that's not going to change, right? Like I think that's something you have to do on your own.
Yeah.
But it's a lot. I think women carry a lot,
Yeah.
and this transition is very difficult, such that most women don't feel like themselves.
Yeah.
There's other things that happen from a health perspective, right? Like there's your body image that changes.
Right.
People develop visceral fat, midsection fat from menopause.
Mhm.
They might feel like they're aging and like they don't feel good about how they look anymore.
Right.
Some people develop cancers in midlife, and then their breasts are so attached to their sexual function.
Mhm.
So I feel like there's a lot into the equation.
Right. And I mean, I'm exhausted just hearing all the things that you just said that, cause a low libido. But I mean, and this is the thing, right? Women feel like they have to do something about it, right? They're
Yeah.
exhausted, they're stressed, all of these things are happening, but yet they feel responsible
Right.
completely that like there's something wrong with them, that they have a low sex drive, and they're not quite taking into consideration all of these things that are happening.
Yeah.
And I feel like that's a narrative in the world too. It's like, oh, why do you have a low sex drive? What's wrong with you?
Yeah. And not only that, like, I'm not a urologist, but my urology buddies tell me this all the time, like, because they take care of both the men and the women for women who have sex with men, is that like 40% of men get erectile dysfunction by age 40, 50% by age 50, and the statistic goes up. And so you're then dealing with the fact that like you might not even receive any pleasure, right? You might not be able to have like pleasurable encounter, that this is something that you're just like, everyone's doing their to-do list while they're having sex.
Right.
And so I feel like, you even taking into the equation, like what the issues are with your partner, like what are they experiencing?
Right.
It's just layers of problems.
Right. And so from your perspective, with all the patients that you've seen, what would you say are like sort of maybe the top 3 reasons? Because you've told us a lot of reasons that libido goes down in midlife. What do you think are the top 3 reasons that libido goes down, and what could someone do about it?
Yeah, I think there's issues that come about with sleep and energy, right? So like, I think that's a big problem in midlife, right? As our hormones start to shift, as we get up in the middle of the night to pee, as we have ruminating thoughts that keep us up, as we're attached to our technology and we're just doom scrolling all night. I feel like women don't sleep enough. And then when you're not sleeping enough, you have a cascade of things happen, right? So I do think sleep is a major factor. I think the hormone dysregulation, like, as we get hit into menopause, I always say when your ovaries are retiring, they kind of go out with a bang, because you have, we can go through the basic definition of menopause if that will be helpful. But I do think menopause and perimenopause and the hormonal shifts are really big. And then I think, some of these issues around stress and the longevity of a relationship and the lack of spontaneity and the lack of spontaneous desire. Those areas, I think, are 3 areas that I always try to get my patients to work on, right? Around stress, around sleep, around hormones, and then some lifestyle modifications. I feel like those are the areas we can attack. But I think it's worth mentioning some things about menopause and how that impacts.
Yeah, no, let's go there. Maybe we can start with the definition of, menopause and how this plays into sexual health and sexual wellness.
Yeah. So, menopause, we define very poorly as 12 months without a menstrual cycle. And so it's this diagnosis that comes about retrospectively. And the average age of menopause for most women is 51 and a half in North America. For Black women, it's earlier. For Latina women, it's earlier. For South Asian women, it's earlier. So meaning that when your ovaries finally retire and you're now in an estrogen deprived state, it really can impact you from head to toe, because we have receptors for estrogen from head to toe. So for some women, like South Asian, we're both South Asian, average age, depending on the study you read, is between 47 and 49.
Right.
And then actually there was a recent study that came out that looked at sort of the Masala study, which was the study around cardiovascular risk for South Asians. Because as South Asians, as you know and talk about, is that, we are like, 25% of the world population, but 60% of the world heart disease or something like that, right? And so they looked at the women in that study, and a third of South Asian women went through premature menopause less than age 45. So that's pretty pronounced, right? Like to lose that estrogen that early, that affects you from head to toe. So what happens to women is, if you think about the brain, what happens cognitively, people get distressed around cognition. They think they're getting dementia because they have brain fog. They can't think of the next, why did I come in the room? I don't remember. They get ruminating thoughts, anxiety, depression. And it's really depending on how sensitive you are to hormonal shifts, right? Because
Right.
In your 40s, your progesterone kind of just like baseline decreases, but the estrogen becomes very erratic, as we're losing our eggs, because you're born with every egg you'll have, right? And they
Right.
just exponentially start to decrease in your 40s. And eventually, your estrogen is responsible for making your eggs. And so if you're not getting a consistent amount to have that normal cycle, there's months that people have very low estrogen.
Right.
And so they have symptoms of low estrogen, but the next month you might have estrogens in the thousands. And so you get symptoms of high estrogen. And so it's the delta from high to low, because your brain is confused. It's sending signals to your ovaries.
Right.
You're trying to get the estrogen out of the ovaries, and there's not there 1 month.
Right.
You might have too much the next month because you super ovulate. And so we have these loop cycles, which are the luteal out of phase cycles. And so people have a lot of distress from really the hormonal sensitization of the ups and downs of what's happening with them from an estrogen perspective. And so we talk about cognition, we talk about our, musculoskeletal health. We think about movement. Movement is life, right? And you can't move well in your perimenopausal state. A lot of people start getting joint pain. They get frozen shoulder. They get plantar fasciitis, all this, what we call musculoskeletal syndrome in menopause.
Right.
And then it affects your genitals, right? The genital urinary syndrome menopause by year, 7, 8 of postmenopause, like 86% of, it's like symptoms that almost every woman have.
Right.
And so it's really around the estrogen receptors in your vulva, your clitoris, your vagina, your vulvar vestibule, which is responsible for painful sex. And because you have less estrogen and slowly declining testosterone, which your ovaries make 50% of your testosterone. So when they retire, you're losing half of the testosterone. I check testosterones all day on women and they're like, undetectable,
Right.
So, and people don't realize we actually have more testosterone in our system than estrogen as women. So we need that testosterone. And it is a mediator of sexual function. So we have this genital urinary syndrome menopause that comes up from lack of estrogen and decreasing testosterone. And what happens is people get urinary frequency, urinary urgency, recurrent UTIs. People don't want to have sex when they know they're going to have a UTI right after.
Yeah.
I have patients that actively avoid it because they're afraid they're going to get a UTI.
Right.
It's miserable, right? And we know that UTIs in like elderly population are deadly.
Yes.
It's not just vaginal dryness. It's not just painful sex. It's whole genital urinary syndrome.
Right.
And so you have this pain on penetration. You might have pelvic floor dysfunction because your muscles become really high tone and they lose vascularity from the lack of estrogen. All of these things combined, and people have, no wonder you don't want to, if it feels like sandpaper or it feels like, sharp knives in your vagina every time you have sex, you're not going to want to do it, right? So I think that it's very important to realize that your body is changing from a multi-organ perspective, that menopause is a state that we all will go through if we were lucky enough to live long enough, right? Some people have abrupt menopause because, they have cancer therapies, they have hysterectomies with the removal of their ovaries, they have premature menopause or primary ovarian insufficiency. Those patients tend to suffer even more because they're losing estrogen up to 10 years before they should.
Yep.
So they develop all the cardiovascular disease, they develop cholesterol problems, they develop dementia, they develop all these problems. And so that's why it's so important to find someone to help navigate this with you, which is not just hormone therapy. It's controlling the stress. It's getting you to sleep. It's getting you healthy from a muscle standpoint and a visceral fat perspective, because we know that goes up in menopause as well.
Right. So there's so many things to really be thinking about. It's not just your libido's going down. It's just like a whole, what you're trying to say is that it's a whole multi-system issue.
Right.
It's not just your reproductive system.
Right.
It's a whole interplay of many systems. That's the problem.
Right.
Okay, so I would love to ask you more questions about genitourinary symptom, because I think that so many people have questions about what that is exactly. And I know you explained it really quickly, but could you explain a little bit more? Because so many women have it, right? I know I've read studies that it's at least 50% of women will experience this.
Right. And I think almost 100% of women will have one symptom from it. Like they might not have the whole syndrome, but, someone's going to experience vaginal dryness at some point. They're going to experience painful sex or urinary frequency or urinary urgency or, one of these symptoms. And so again, because the genital urinary tract, which includes your vulva, which includes your vulvar vestibule, which is the opening of your vagina, which includes the vagina, it includes the clitoris, it includes all these end organs, have both the estrogen and testosterone receptors. When you lose that, you lose vascularity, you lose collagen to the area, your vaginal microbiome essentially changes. And so we know we have bacteria in our vagina that help us keep a normal pH, and that pH starts to shift when we have these genitourinary changes because of lack of estrogen. So estrogen is important to keep the pH acidic. And when we start having a basic pH, we're more susceptible to infections like BV, UTIs, and other things. And the bad bacteria can proliferate. And also when we don't have that good pH, we don't have the good glycogen storages that help maintain, collagen production and all the things that are really important for our vaginal health. So when our vaginal health suffers, the vagina can shrink. The labia can disappear. The labia resorb, actually. Like I'll sometimes show a mirror to a patient. I'm like, you see your labia minora, the small lips of the labia, they're looking almost infantile now because it doesn't have the estrogen and testosterone that it needs locally, and they shrink up. And so for some people, they're happy about it because they had elongated labia. Other patients were like, oh no, that's why I'm experiencing even more pain with friction even. Like, right, if you're wearing tight pants, you can have some frictional issues. And then, of course, the urinary symptoms. People always think they're having a UTI, or so they get misdiagnosed with interstitial cystitis, and it's a real problem for them.
Okay, got it. So that makes sense to me. I think that so many women are so confused by it, right? And it's scary. It's scary to feel like you are having all these symptoms you've never had before, and then they intensify so much.
Yes. Right. It's chronic progressive. I think that's very important to say that it's untreated, then it continues to get worse.
Right. And people don't get help for it, or they don't know what to do. And then they feel shameful and they feel like it's all their fault. Right.
Yeah,
so this is again, also women having so much to do, feeling like they have to carry the whole world on their shoulders, but then they're also responsible for having sex, and, they feel all of these things. So I think it's just this very complicated whole system that's going on.
Yeah.
What are the treatment options that actually help with this?
Yeah. I mean, the standard is really topical vaginal estrogen, so local estrogen therapy. So there's systemic estrogen therapy that includes treating all the system impact that you're having. But this is actually treating you locally. So it's almost like a microdose of estrogen to the vagina that will make the tissue youthful again. Let's make vaginas better again. I always say I'm making vaginas great again in my office. So it's interesting because I think that, a lot of people are scared to use hormones, but this is the one hormone I think when we use it locally and we're treating the deficiency that it is, will have the most impact. And actually my favorite form of local hormone therapy is really vaginal DHEA. Its trade name is Intrarosa. And DHEA is significant because from it's an intrachronology perspective in the tissue, it will change into estrogen and testosterone. So it gets converted to both. And we have receptors for both in the vagina and the vulvar vestibule, which is at the opening. And so when you get that hormone to this area in a local fashion, in a dose-dependent manner, it's transformative to people.
Right. And so I really think that most women don't even understand that there is a treatment that is local that actually can help with the painful sex that they're having, with the dryness, all of the discomfort that they're having, that there's something that's quite simple that might be a treatment option.
And the reality is it also decreases risk of recurrent UTIs by 50%, both vaginal DHEA and vaginal estrogen. That's why we say it's life-saving, because if a quarter of women who get UTIs or recurrent UTIs end up in the ICU with sepsis, and something like 6% die from sepsis in the geriatric population. Obviously then if you use something to reduce that risk of dying, then it is life-saving, right? And so there was this study that came out at the AUA this year that actually showed that it did reduce mortality in these patients, the use of vaginal estrogen. So, I mean, again, vaginal estrogen, vaginal DHEA is not just about vaginal dryness or sexual pain. It's really a life-saving measure that every woman can almost be on if they feel like they're able to take it, right? And we have different forms that we can use. We have creams, we have tablets, we have suppositories, we have rings, we have an oral medication that works locally in the vagina. So for people that I have patients that are like, I don't like doing stuff down there. And so because of the shame that they carry, or because maybe they're elderly and they can't, do things as much, they're not mobile. And so then sometimes we can give them this oral medication called ospemifene, which is in the family of tamoxifen and those other medications as a selective estrogen receptor modulator. So it's really estrogen positive on the vagina and vulva.
So I have a question for you. I mean, if for women who have gone through breast cancer and have had an estrogen positive tumor, hormone therapy is usually off the table for them. But can they do something that is a local estrogen like this if
Absolutely.
they're having these issues?
Absolutely. And I think the tide has turned finally. I think for a while we were just offering moisturizers and lubricants, but now we know that, and there's been studies that have been done to show that it is safe because, again, even though it's locally absorbed through vaginal tissue,
Mhm.
it doesn't increase your baseline estrogen level above the postmenopausal baseline. Meaning, yeah, there is some systemic absorption, but it's not above your baseline postmenopausal level. So we're not
Mhm.
actually giving you enough that's going to stimulate anything from a system perspective.
Got it.
And so for most women, even though there's a fear factor involved, and there always has been, they
Mhm.
can use that. And despite there is a boxed warning on vaginal estrogen because the FDA classifies all estrogens the same. So even if
Right.
it's a microdose local therapy, they will classify it. But there's been no cancer associated with, no blood clots. If anything,
Mhm.
mortality decreases when you use vaginal estrogen. And DHEA has no boxed warning because it's not an estrogen, it's a DHEA. And so
Right.
that's my preference, and that's what I use on most of my patients. And it used to be, I think, because I've been in this space for 11 years now. And so we would try to give breast cancer survivors like the Mona Lisa Touch or the lasers that don't have a lot of great data, but because they weren't hormonal, it was an option for them.
Mhm.
But these things are not associated with the major risks of estrogens that have been shown previously.
Okay. That's really helpful
And
to
if
know.
you think about it, there are some people who are now saying, and there was an article that just came out, or a menopause statement just came out from a breast surgeon who said it might be time for us to even rethink the possibility of systemic estrogen in some
Mhm.
patients that have suffered from breast cancer who are remote from their breast cancer. Every person is unique, but my
Sure.
friend Dr. Corinne Mend calls it the pink elephant in the room. What about these
Mhm.
women who, have had breast cancer, who haven't been able to use the hormones that are protective for their bones,
Right.
that are protective for their heart, that might be protective for their brain if they take it early enough? So a lot of breast cancer survivors, and you may be in that situation where you feel like you got the short end of the stick because you can't take the estrogen that might have been protective. So some
Right.
people, and I have this discussion with patients, I review all the data with them. If they're
Mhm.
remote from it, it's worth a discussion, right? Like to see if
Right.
it's going to help or harm. And sometimes, we can get the oncologist on board, sometimes not. But we have to
Yeah.
remember estrogen is so important for our bones too. And that's one of the
Right.
major reasons we give it, that if someone
Mhm.
develops osteoporosis and then they have a hip fracture, they have, anywhere from a 20 to
Yeah.
30% mortality associated with that.
Right. Right. Yeah. I mean, it's such a complex issue. And so I think what you're bringing up is that it is, it's unique to each person, and making blanket statements about, who can get estrogen or vaginal estrogen or not. I mean, it's really got to be a case by case basis.
Right.
And
Right.
I think that's really, again, points to why you really need, for all the women who are listening, if you're in this stage and you have lots of questions, you need to go to a provider who has trained in this, who's an expert, who can really help you weigh all of the options,
Right.
because they really understand all the options.
Right. And it's a nuanced decision. And most of us, we call it precision medicine. We're not going to do patriarchal medicine anymore, where
Right.
I'm going to dictate, I'm going to present data. We're going to talk about what you want, what are your lifestyle issues. And we're going to come to a conclusion that we both feel comfortable with, knowing that there are some areas that we don't know.
Right.
My friend Rachel Rubin always says, like, what are we afraid of? Like, what are you afraid of when it comes to any of this? And
Mhm.
obviously we're afraid of like harming our patients and all the things.
Right.
So it has to be a shared decision, and it has to be a nuanced conversation. And hormones aren't the like silver bullet to help everything,
Right.
but they're part of the toolbox that we can potentially use.
Right. Right. And I think that's important too, because there's so much, sort of like it's either this or that. And
Yeah.
people are so on the extreme, like everyone should have hormones.
Yes.
No, you shouldn't
Nobody.
have hormones. And I think,
Mhm.
again, you're providing that perspective that it is very nuanced, and
Mhm.
it's just part of the toolbox
Yeah.
that we don't need to be afraid of, and that we need to be able to have these discussions with our provider about
Absolutely.
what are the risks and benefits for us individually.
Right.
you know,
Absolutely.
right?
It's very
So
important.
I have a question about Kegels,
Okay.
and pelvic floor dysfunction and
Yeah.
how this all fits in.
Yeah.
So many people, especially younger women, actually, I'm finding, I have a 23-year-old daughter, and like so many of her friends are talking about Kegels and pelvic floor dysfunction. Like, these young women are like so educated in this.
Yeah.
So let's talk about Kegels and what happens with pelvic floor as we, get into this midlife, and what can we do about it?
Yeah, I mean, so it's really important to understand that the pelvic floor dysfunction comes along with midlife issues, not only because you're not getting that blood flow from the estrogen and the hormones to the area that feeds the pelvic floor, but also the way our lifestyle and our society is right now. Like I
Right.
always say, if you're clenching your jaw because you're anxious
Mhm.
about something, you're clenching your pelvis. And over
Oh,
clenching of the pelvis. So, and then I'm also like, if you're not clenching, then you're actually not paying attention because like the world is on fire right now. So,
yeah.
but I think that this is what happens to so many patients is in one aspect or another, they experience pain. Maybe they have painful sex. Maybe they're clenching because they're anxious. They're, ruminating thoughts. They're anxious and they're clenching. And so when you clench your pelvic floor muscles are a bowl of muscles that surround your vagina. They support your bladder, your rectum, your urethra. And so they're really important for your sexual function, your bowel function, and your bladder function. So some people suffer from like constipation or urinary urgency or frequency, and the hormones are helpful, but they also need pelvic floor therapy. And then the patients that have sexual pain for sure, because what happens is, we talk about, incontinence and some of these things that come up with midlife, right? Where you cough, 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 sneeze, 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 and you pee on yourself.
Mhm.
But, because of pregnancy and just the heaviness of a pregnant uterus on your pelvic floor can cause pelvic
Right.
floor damage. And then the lack of the hormones causes even more damage. So become weaker over time. But what also makes them weaker is the high tone pelvis. And so when people are clenching, they're kind of shortening their pelvic floor muscles. They become shortened. They become more taut. You can imagine Charlie horse in your leg or a knot in your shoulder that you feel from
Mhm.
a trigger point. People develop
Right.
these in their pelvis. And so
Mhm.
then the muscles don't contract in coordination, so they can't get stronger, they get weaker. And they also just lack that blood flow to the area because they're losing the estrogen and the testosterone. So the muscle becomes hypertonic. And so when I feel the pelvic floor muscles, like people are like, ow, what are you doing? Like you can feel
Mhm.
some really tender spots. Just like, again, just like if you have a
Sure.
tight knot in your back or your neck and you can massage it out. That's the same thing.
Mhm.
And so pelvic floor therapy uses tools to elongate the muscles to try to get them stronger. You have to reduce the tone and you have to get them stronger. And that's what Kegels do, right? Like you're supposed to be clenching and holding, and that's supposed to strengthen your muscles. But some people just clench and they don't release. And so that's why people run into trouble when they over Kegel. If you're over Kegeling, there's also like this in the pelvic floor, therapists have tons of pelvic floor therapy friends, and they're like, to Kegel or not to Kegel, right? Like, because some people are just Kegeling all the time, and they're creating
Yeah.
hypertonicity in their pelvic floor. Or
Right.
we have people that are just like doing their abs like crazy, trying to build, and so sometimes overworking the core can do that as well. Or when you have a hip problem or other problems, you can develop pelvic floor issues. So it's
Mhm.
so important for so many factors. And pelvic floor therapy is always, that's why I have a pelvic floor therapist in my office. It's always part of the regimen
Mhm.
to help midlife women overcome sexual problems and genital urinary
Mhm.
problems and bowel problems. Sometimes it's just constipation. They don't have anything else. And it's like, okay, you're
Mhm.
not allowing it to come out the way it needs to.
Right. And so really what you're saying is that it's not always clear that everyone needs to be doing Kegels
No.
because you might have a hypertonic pelvic floor.
Yes,
Yeah.
exactly. And you're just
Yeah.
contributing to it then.
Right. And so how do you know? I mean, what are some of the specific signs that you might have pelvic floor dysfunction?
Yeah, I mean, so I always ask patients like, is there burning at the opening when you're having intercourse? So like, the vulvar vestibule is the thin area of tissue that surrounds the vaginal opening, and
Mhm.
it has estrogen and androgen receptors, so it needs both hormones. And the bottom part of the vestibule is kind of where those muscles kind of insert. And so when people get a high tone pelvis,
Mhm.
we can see people develop burning at the opening because of, lactic acid buildup and all these other things
Right.
that cause burning at the opening. And so that can be an issue. So painful sex, burning at the opening, inability to have, like we see this a lot in South Asians, especially, patients that are just, getting married or having sex for the first time. They have pelvic floor dysfunction or vaginismus is what it was historically known as, which is an involuntary contraction of
Right.
the pelvic floor.
Right.
I think the statistic is like upwards of 40% of South
Mhm.
Asians develop it in our lifetime, sometimes even more. And so some of that comes with like almost an anxiety of your pelvic floor muscles where you're clenching because you're afraid of penetration because of the layers of shame around sex, because of the I wasn't supposed to have sex till I'm married kind of thing. Or, now I'm married and I can't have sex. I have a lot of patients coming with unconsummated marriages. And so you have this pelvic floor dysfunction that doesn't allow for penetration. So you might not be able to have a pelvic exam. You might not be able to have tampons placed. You might not be able to have any kind of penetration at all with any tools or toys or anything. So that's another one. Bowel dysfunction, where you're having a lot of constipation. You can't have a full evacuation, that kind of thing. And sometimes people develop these herniations in their bowel from their rectum into their vagina. That's called a rectocele, or a herniation of the bladder into the vagina. That's called a cystocele. So some of those things contribute to this bulge sensation they might have.
Right.
And then there's, the urinary issues, right? Sometimes dribbling, sometimes, frequency, sometimes pain, all of the things. And sometimes when you work the pelvic floor muscles and you get some pelvic floor therapy and use dilators and other tools, it helps a lot.
Right. So how early should you start doing pelvic floor therapy or exercises or Kegels or whatever?
Yeah. I mean, I always say I would think about what you're experiencing, right? Like if you're someone who has never if you're, say, a young patient listening to you and they're about to have sex for the first time, but they can't, or they've tried to use tampons and no matter what, they can't get it in. They feel like they're hitting a wall. That wall is your pelvic floor. And so if you can't find a gynecologist or urologist or someone, a primary care that can help navigate that for you, most people can find a pelvic floor physical therapist that will help navigate this for them. And so that is a big thing with that, which is vaginismus, involuntary contraction of the pelvic floor. If you're having, you keep thinking you're having a UTI, and it comes up culture negative all the time, that's a sign and symptom that you might need to see someone for pelvic floor therapy. But also, is there something happening hormonally, right? That vulvar vestibule, when it doesn't have estrogen locally or testosterone, the androgens, it can really also get this feeling of urinary frequency, urinary pain, all the things. And just as a side note, sometimes we see that not just in menopause, right? We see in other states of hormonal deficiency. So there are patients who maybe are having fertility treatment and their hormones have been suppressed. There are patients on birth control pills. And there's a subset of those patients whose hormones get suppressed very early. And they actually develop what is essentially the genitourinary syndrome of menopause, because the birth control pills suppress their natural hormones by preventing ovulation and giving them a synthetic hormone, but also suppress testosterone. And that testosterone is a really important factor there. So I have young 20-year-olds that they come to see me. They've been on the birth control pill since they were 13. And lo and behold, they have this hormonally associated vestibular pain in their vulva. And so we treat it just like the genitourinary syndrome menopause. And then there are patients who are postpartum, right? When you're lactating, your estrogen is suppressed, you're in a postmenopausal state. Same thing. So, this applies for every patient across the board. And so all those patients usually need pelvic floor PT. It should be part of everybody's fourth trimester care, right? To build back those muscles, vaginal delivery or C-section. You need to get some pelvic floor physical therapy, because just the weight of a pregnancy on your pelvic floor can cause a weakening. So I think if you are in any of those categories, if you suffer from constipation, get a good GYN exam. If you can't, see a pelvic floor therapist and they can help you.
Okay. Sounds like everyone needs, most women really should be thinking about this pelvic floor therapy. Just as preventative also.
Absolutely. Right? And think about are you clenching your jaw? Do you have TMJ? Do you grind your teeth at night? All of these things usually mean that something's happening with your pelvis too.
Interesting. That I never would have thought of that. That's a really good tip. So, where can people start if they are having libido issues, and also the sexual pain? I mean, they all kind of go together. These are two, like you said, two of the most common complaints that women have. So where do we start? What do we do? What would you say to someone? What are some things that you can do to start helping yourself?
Yeah, I mean, really, I think, getting a mirror, taking a look down there, just get yourself educated on what your anatomy is. I think bringing it up to your gynecologist, your primary care, whoever. I mean, sometimes the problem is I know that this knowledge isn't available to all, there's a generation of doctors that never got trained on menopause because of the Women's Health Initiative. But there's also this sexual medicine as an entity has really blossomed in the last 25 years. So Dr. Irwin Goldstein, who's a urologist, really helped to propel the field of sexual medicine for women. And he started the International Society for the Study of Women's Sexual Health, which is ISWISH, which I'm on the board of. And it is an organization that's dedicated to studying women's sexual health, to training doctors and clinicians for women's sexual health, and for treating it in a really multifaceted way. That we have physical therapists, we have sex therapists, we have psychologists, we have internists, we have urologists, we have a whole spectrum of nurse practitioners. And so I think it's really important that we have this collegial organization that really works for women's sexual health. And so you can go on the website, www.isswsh.org, wishishwish.org, and you can find people that are members. That means that they've probably attended a conference.
Sure.
So they might have some knowledge. You can also find people that have become fellows like myself, which means we've been working with a mentor. Like I worked with Dr. Goldstein.
Right.
People have worked with different people that have been in the field a lot longer and gotten some more training.
Right. I'll make sure that we link that in the show notes for everybody if you didn't catch the website.
Yeah.
Okay. I have a couple of listener questions because I actually put a call out for some questions and there were a couple that came up. The first one is, how does hormonal birth control, like IUDs or the pill, affect libido and arousal? Is there any connection? Does it have an effect?
Yeah, absolutely. The pill specifically, I think, as we were discussing, there's a subset of women who do have, and the data on libido is a little up and down because there are some patients who, do better on the pill because it clears up their acne or because it controls their endometriosis pain or they controls their PCOS symptoms or other conditions. So they feel better when they're on the pill. But we also know that the pill, from a biologic perspective, there are pills that have a certain type of progesterone in it. And some of them, the reason they treat acne is because they lower your testosterone. And again, testosterone is so important as mediator of your libido and your sexual function, that some people have a change in libido and sexual pain. Like we just talked about the genitourinary syndrome of menopause that's associated with birth control pills. And so there is a subset of people who don't get as aroused and they don't get as lubricated from being on the birth control pill. And partly that's because of lowering the testosterone. It also will raise a protein called the sex hormone binding globulin. So it's a protein that is produced by your liver, and your birth control pills are metabolized through your liver. And so we do get a rise in this protein that then binds up the testosterone that you might need in other cells and other tissue.
Got it. Okay. So there is definitely, there can be a correlation.
Yeah. Now, we don't see it as much with the IUD, but I have patients who swear that the IUD causes their low libido. And maybe that's related to, they're feeling anxious about it or, there's like, it's multifaceted, right?
Right.
I believe a patient if she thinks that it's from that. We don't have the studies that necessarily will correspond with, yes, it lowers your libido because at least from a biologic perspective, it doesn't seem to do that. But maybe from a psychosocial and some of the issues, I think it could.
Right. And then the other question that came up is, is there a connection between your gut microbiome, your gut health, and sexual function?
Yeah. I mean, I think we know their connection with the brain and the gut, right? So if your brain is your biggest sexual organ, I haven't looked specifically at that data, but I've seen it, where people, they suffer from IBS, which is probably related to endometriosis and other things. And if you don't feel well from a gut perspective, if you feel bloated, if you feel like you got to go all the time or you can't go, like, when you're really constipated, you feel bad and bloated and bad about yourself, then of course your sexual desire is not going to be there, right? Like it's just natural. And then you develop pelvic floor dysfunction, which means sexual pain might be the next thing to come. So there is an intricate link. I don't know how much it's been studied, but we see that link clinically all the time.
Yeah, clinically. I could keep asking you questions.
Yeah.
But I have something I wanted to, ask you about. There's a connection round that I do at the end of every episode, which is really sort of like a lightning round, but it's really to create more connection because I think that's the whole point of being here on this earth. And also why we're both physicians. And so I would love to ask you a couple questions so I can get to know you better and the listeners can get to know you better.
Okay.
So what is something that brings you instant joy?
Instant joy. My children, I think, bring me a lot of joy. Helping patients bring me joy. Like when I have a patient that feels really like, like I've kind of changed their outlook for me, that brings me a lot of joy. Being in the sun brings me Like the sunlight, I'm like, oh, so I'm very dependent on that. And I think, in, like exercise and those kind of things, like I may
Mhm.
not be motivated to do it, but once I do it, I feel very happy about it. So.
That's great. What is something that makes you feel seen? And can you give me an example?
Yeah, I think when either other clinicians come to a, where they may have been in doubt before, where they didn't believe
Yeah.
that, like the whole idea of vaginal estrogen being life-saving, right? I posted about this a few years ago on my YouTube because I talked about how my mother-in-law, who's unfortunately passed since then, who did not get her vaginal estrogen, developed a UTI, ended up in sepsis in the ICU,
Mhm.
and how it was life-saving. And then when she went back on it, I feel like that kind of got caught on for a lot of people to, and
Mhm.
I feel like that concept of it being life saving has really started to be picked up in with multiple people. And I
Mhm.
think that this is now becoming a thing where people do believe that this is something, and we have now data to prove it. So I feel like that is something that I'm like, yeah, that's good. I'm happy about
That's
that.
great.
Yeah.
That's great. And lastly, so what is a song that makes you feel most alive and why?
Oh, I don't know. Lately, I mean, there's so many. Like, because I was going on a walk run with my little girl the other day, and she was playing Pink Pony Club. And she's like, "Mama, let's dance to Pink Pony Club." I was like, "Okay." Or that Watermelon Sugar High. She was like playing all these playlists. And I was
Yeah,
like, "Yeah, this makes me feel good." Like,
that's awesome.
yeah,
That's awesome.
yeah,
And so the last question I have, the name of this podcast is The Healing Catalyst. And so, healing is not easy. It's a journey. And we've talked about so many things that are not easy to do, right?
mhm.
To tune into all of these things. What's one simple thing that you think our listeners could start doing today to really support their sexual health and sexual well-being?
Yeah, I think knowing your anatomy, your anatomic parts, I feel like that because we shame so much of our vulvar and of our genital urinary anatomy that we just call it down there. We have
Mhm.
all these euphemisms for it, but actually
Right.
naming the anatomy and naming what's happening is very
Right.
powerful for people, right? Like I have
Yes.
patients that tell me so many times that they've been, I treat so many various sexual dysfunctions that and they're told consistently this is something that happens in their head,
Mhm.
and that they should have wine, that they feel gaslit by so many people because of it.
Right.
And when I give them a name for what they have, it's very powerful. I think the same thing, like if you can understand your own genital urinary symptoms, if you can educate yourself, right? I always say no
Right.
one's going to save you, right? Like in and I think people expect doctors to do that or their
Right.
clinicians, but at the end of the day you have to know what's happening with your body. And I
Right.
believe a patient when they tell me X, Y, and Z is happening to them, right? Like I
Mhm.
believe them, and I take what they say very seriously. So I think really being in tune of what's happening to you and educating yourself on that. So
Mhm.
that's very empowering, right? Like I have the most empowered patients because they are so well educated. They come in, they know what they want, they know what, they've read up on it. So I find
Mhm.
like that's like the first thing that you can do is just
Mhm.
to educate yourself on your own anatomy. I mean, I teach my
Right.
kids the correct anatomic terms and people look at me like, "What? Did she just say
Mhm.
vagina?" Or,
It's important, it's
yeah,
important, I
yeah,
agree 100%,
yeah,
yeah, it's really, really important, and it's a very powerful thing to be able to take that back because, as I, sort of talked about at the beginning, you being a South Asian woman, South Asian physician in sexual medicine is so radical and so amazing, and I am
thank you.
so here for it,
Yeah, thank you.
that, for us to then also take that back because it's more than just South Asian women, but, culturally, women have been so shamed about anything about sex and
Yeah,
about their,
yeah,
anatomy, that I think that what you're talking about is so empowering.
yeah.
So
And
thank you for
I'm a
that.
big believer in bringing it back and taking it back. And I think I told you, Avanti, that I'm writing this book.
Yeah.
And the title of it is Brown Girl's Disease, question mark, a guide to sexual health and empowerment through a South Asian lens. And I chose that title because so many women do suffer from pelvic floor dysfunction, vaginismus, and sexual pain in the South Asian community, in the brown communities, such that, when I was in training, it was almost like this funny thing, like, oh, she's got brown girl's disease, like, oh, all these, oh, what's up with your people? They all have the same problem. And
Right.
so I was like, you know what? I'm going to take that term and I'm going to empower it now. Like,
I love
you
it.
know?
I love it. I can't
So,
wait for your book to come out. I think it's going to help so many people.
oh, thank you.
Again, because, it's about taking back that power.
Yeah.
Sameena, thank you so much for being here and for this conversation. I think it's going to really empower a lot of people. So
Thank you.
thank
I really
you.
appreciate being on here.
Wow. This conversation with Dr. Rahman was such a powerful reminder of why I am so committed to having these conversations on this podcast and really bringing these discussions into the light. I have to say that when she said, take a mirror and look at your vagina, I flashed back to the very first time that I ever did that. I was 27 and pregnant with my first child, and my OB-GYN handed me a mirror and said, take a look. And that moment was eye-opening, quite literally and figuratively. And it really made me realize how disconnected so many of us are from this part of our own body. And maybe that shock or discomfort is exactly the point, because the fact that so many of us have never done this, including me being a physician, going to medical school, the fact that so many of us have never done this really tells us everything that we need to know about the silence and the shame that we've grown up with and how deeply it runs. And that the only way we can really change this is by talking about it out loud together. And then there's what might be my favorite takeaway from this whole conversation, her reminder that our brain is our biggest sexual organ. As a physician, I know this, but I don't think that most women really think about it. And it's so important because sexual health isn't just about hormones or physical symptoms. Yes, those are important, but it's also about our thoughts, our stress, our emotions, and how we connect with our own desire. And that insight alone could change so much for so many women that will hear this podcast. And so here's my challenge to you. Be brave. Share something that you've learned from this episode, or share the episode, please, with a friend, a sister, your partner, because it's really up to all of us to change this narrative. Every time we speak up, we make it easier for someone else to do the same. And if you want to learn more from Dr. Rahman, make sure you check out the show notes for all the links to all the things that she's doing. And I'm also linking a fantastic resource that she mentioned on the episode, the International Society for the Study of Women's Sexual Health at isswsh.org. And as always, thank you for listening. And thank you for being part of this really important conversation and this community. Remember, healing isn't just possible, it's in your power. Until next time, be well. Thank you for listening to The Healing Catalyst. If you found this episode helpful, please hit follow and share it with a friend. And if you feel inspired, please rate and review because it helps others find this podcast more easily. For more insights and tips, head to my website at avantikumarsingh.com. And to connect with me directly, find me on Instagram at Avanti Kumar Singh. I loved sharing this episode with you. My hope is that you heard something today that sparks a catalyst in your healing journey and helps you build lasting health. Be well, and I'll see you next time. This is a Dante 32 production.